Hello everyone, my name is Mary Stone and I'm a certified surgical assistant, and I've made this presentation for my master's bridging program. And I have been a certified surgical assistant for 8 years now, and I work at Norfolk General Hospital, which is a level 1 trauma center, and I really enjoy what I do. And the reason why I picked this presentation was because being a level 1 trauma center, we do a lot of cervical procedures and we have a lot of turnover and we have different people coming through. And I found that it was important to go into this and help teach people the right way to do things. So I'm going to go ahead and move on to the next slide. So my purpose statement, So the purpose of this training program is to present effective strategies to operating room personnel at Anterior Norfolk General Hospital for the safe and effective care of a patient having a surgical procedure known as an anterior cervical discectomy infusion. So this is what I'm going to be talking about. So my instructional goals. So here I'm just going into what all the roles of the OR should pay attention to when doing this procedure. First and foremost, the surgical assistants need to be able to identify necessary patient positioning items for the case and describe the anatomical and surgical steps of the procedure, including all necessary instrumentation. And then the registered nurses need to be able to discuss the start to finish steps of the procedure related to patient care and not to include anatomical steps. The surgical technologist should show proficient knowledge of surgical instrumentation setup and should demonstrate the proper handling of instruments. And everyone should compare their role as staff to the other operating room staff and know the importance of each person. And everyone should be able to distinguish and discuss alternatives in surgical methods related to surgeons' preferences. So this is my outline. I'm going to talk about these 7 things here. My first thing that I'm going to talk about, identifying proper positioning items. So that's very important when you're setting up the case. The next thing I'm going to talk about, I will describe the anatomical and surgical steps. And then third, I will describe the patient care steps before and during surgery. Number 4, I'm going to talk about the proper surgical instrumentation setup, and following that, the proper handling of the instruments. And then knowing your role and alternatives and surgical methods related to doctors' preferences. So, first thing, so we're going to talk about patient positioning items. So, we need to correctly position the patient for surgery because it is essential for the outcome of the patient. Patient positioning is surgery dependent, so each case requires different positioning and tools. So basically, if you're doing a ACDF, which is what I'm talking about, everything's going to be set up pretty much the same way. If you don't set up the patient correctly, they can have ulnar nerve problems, they can have back problems, just things that you don't want to worry about. And then incorrect positioning can hinder the surgeon and assistant as well as injure the patient, which I just mentioned. And all positioning tools need to be in great condition and correctly developed. So basically, if you're making a rolled sheet, you want to make sure that it's in the correct position. It's not folded incorrectly. It's nice and smooth. It's basically stuff like that. So we're going to determine the correct gel or rolled sheet bump and have plenty of egg crate cut and ready to pad the arms. So those are some of the things that I always get ready whenever I'm going to do one of these cases. So this is a picture that I took when I was setting up for a ACDF, and this is an example of some of the things that I prepare for every patient. As you can see here, I have some cut up egg crate, which we'll use to pad the arms because they will be papoosed at the sides. And then I usually make a rolled sheet bump here to go underneath the shoulders. Sometimes, depending on the surgeon, you may put a gel roll, which is one of these, directly underneath the shoulder blades. Or you may just put one under the neck for support, depending on what's going on. But that's typically what you would want to have available. And then after you finish getting that stuff ready, I gather other things such as preps, clear drapes, and x-ray marking tools. So since we are working near the head and neck, there's more oxygen concentration here. So a lot of times the surgeons like to use drapes to cover the face so that there's not as much oxygen concentration because of fire potential. So this is a picture of some stuff that I usually have available. So we have the Mastisol and 1000 drapes, which are used to drape out the neck to block out the airway or the oxygen. And then you want a marking pen, different tapes. Typically we may use the tape to pull the shoulders down in order to see whichever level we're working on. And then depending on the surgeon, I'll bring out some preps and 4x4s because we'll do that occasionally too. And then some towel clips for papoosing and gloves. And then this is actually from the instrumentation set. It's just a stringer that the instruments come on. And the surgeons at Norfolk General really like using it for marking the patient for x-ray. So I usually have that available. So the next thing you want to do is make sure that the OR table is the correct table and make sure it's in the proper position. So you want to make sure that the sheet on the bed is long enough to papoose the arms. I've come into rooms sometimes and the sheet wasn't long enough and then you can't papoose the arms correctly. So it's always good to make sure that it's done properly. So this is a picture of a typical OR table set up for this procedure. You can see that the draw sheet is long enough that you can papoose the arms, and then you always want pillow under the knees, egg crate at the feet, a shea headrest, which sometimes they will change out, and padding for the arms, that sort of thing. And then my next slide will show the correct position for the bed for the procedure. So this is just showing that the C-arm can come in here effectively and not hit the bottom of the bed here, so it has plenty of room to come in here and take x-rays. So then what we do is we will properly papoose the arms with foam padding and large towel clips. And then you want to maintain the hand anatomy and pressure against the patient when you're doing this. And this is something that I've found that's happened frequently with new nurses, that they don't know how to properly papoose the patient. And the biggest thing is making sure you put egg crate all the way down the arm and you maintain the hand against the thigh, And you don't want it to be too tight or too loose. You want it to be nice and snug because they're going to be in this position for a long time. And you want to protect the ulnar nerve, which is the biggest thing here. So once that happens, then depending on the surgeon, we will effectively tape the shoulders down, starting at the shoulder and ending at the foot of the bed. Or we'll apply wrist restraints and tie those together. And the purpose of this is to help the C-arm or the x-ray so that you can see the levels the best. If you're working at levels C7 to T1, that's usually the hardest to see, and in that case you would really need to tape the arms down to help see those levels through the x-ray because the shoulders will be in the way. And then also we need to be familiar with the location of the positioning items in the OR core to facilitate the speed and the preparation. So basically, excuse me. So basically, it really helps when everyone knows where all the positioning items are, and especially for the essays, to be able to get the stuff ready and then do all the stuff with the bed and the positioning, and then they can help do the other things, to get ready for the patient in the case. So this is in summary what we just talked about. So we want to determine the correct gel pad or roll sheets for the patient. You want to maintain proper position of the bed for x-ray. You want to effectively tape the shoulders or apply wrist restraints depending on the surgeon. And you need to properly papoose the arms with padding and be able to quickly retrieve items needed from resources. So that's what we just talked about. So next we're going to talk about anatomy and the surgical steps. So understanding neck anatomy is essential for preparing to assist during an anterior cervical decompression and fusion. So if you don't understand what's going on, then you're not going to be able to anticipate, you're not going to be able to know the best way to help the surgeon. So the surgical assistant should be able to describe the skin layer, muscle layers, the vasculature, nerves, the airway, the esophagus, and the cervical bones. So this is a picture from one of my textbooks. It's just a very general picture to show basic things. I have other pictures that will follow. But basically, the sternocleidomastoid muscle here is one of the biggest ones that we use when we're dissecting. The omohyoid muscle, sometimes, depending on the level, has to be transected in order to see the spine. And the carotid triangle is also very important as well. And then this picture here shows some more things. The external jugular vein needs to be pay attention to it, and this is also another picture of the sternocleidomastoid. Some of this other stuff is sort of important. It depends on which level of the spine that you're working on. My next picture is a little bit more descriptive. So this picture here really shows a lot. So this section here shows the trachea and the esophagus. You can see all of that stuff there. But on the right-hand side, it really shows a lot. It shows the body of the vertebra and the disc. And the biggest thing is the anterior longitudinal ligament. That covers the bone. And the longest coli muscles are also the muscles that we dissect or with the bovie to get down to the muscle. So the picture on the right is really one of the best ones to look at to understand what we're going through when we see the spine. So now I'm going to go into the actual surgical steps. So usually we use an anterior lateral or Smith-Robinson approach. So in this case, a transverse incision is made over the interspace of interest in Langer's line. So basically, wherever you see a fold in the neck, if that's possible, that's usually where we try to make the incision. So the incision is carried slightly laterally beyond the anterior border of the sternocleidomastoid muscle, which is the one we were looking at earlier, almost to the midline of the neck. So it depends on the surgeon. Some surgeons make a very small incision, other ones make a very large incision. It's just dependent on what they like. Next, the subcutaneous tissue is divided in line with the skin incision, and then the platysma is divided, usually done with a bovie. The anterior border of the SCM is identified, and the fascia anterior to this muscle is incised so that we can move it over. The sternocleidomastoid is retracted laterally, and the strap muscles are retracted medially to permit incision of the pretracheal fascia medial to the carotid sheath. And then next, so the sternocleidomastoid and the carotid sheath are retracted laterally, and the strap muscles and visceral structures are retracted medially. And in here you have the trachea, the larynx, the esophagus, thyroid, those type of things. And then now we're going to see the anterior aspect of the spine. And you'll see the paired longus colli muscles, which we later have to dissect off the bone. So now we can see where we're trying to work. So here I have some questions. So what two vessels are ligated once the sternocleidomastoid is retracted? That would be the superior thyroid artery and the lingual vessels. Once the platysma and the superficial cervical fascia are divided, what neurovascular structure is at risk for injury? That would be the carotid sheath, which has the internal jugular vein, the carotid artery, and the vagus nerve. What fascial layer is encountered after dissection through the pretracheal fascia? The pretracheal fascia or retropharyngeal space is encountered. The prevertebral fascia is split longitudinally, exposing the anterior longitudinal ligament, which you mentioned earlier. The longus colli muscle is elevated bilaterally and retracted laterally until the anterior surface of the vertebral body is exposed. So now we're visualizing the anterior body of the spine. So what we're going to do here is we're going to get some handheld retractors, which are usually clouards. They can have a lip on the end or lipless, depending on the surgeon. And then once we see what we want to do, we get the shadow line retractors. So these retractors hold constant pressure, constant exposure for us so that we can not have to have someone holding retractors while we're doing the procedure. So there's a rainbow stick that is used to determine the correct size of the retractor. So this is a picture of one of the shadow line trays that I took a picture of. And this just shows all the different sizes and all the applications that you can use. So these are the handles that screw on to the retractors, and then the rainbow stick is in the right hand corner there, and that just shows how deep the neck is, and you can figure out what color you want to use from that. And then this is another level of the tray. It has more blades, and then it also has the actual retractor system here, which is what we typically use. We don't usually use the one on the right. And then there's some tamps and some other things that we use. So I took this picture because I felt that a lot of people that I've worked with that are new to neurosurgery, they don't seem to understand what the most important components are that you need to have available. So, of course, the rainbow stick, it helps determine what size blades that we need. On the right-hand side, this is an example of how the blades are loaded on the retractor. They screw on, and that's the proper position of them. And then the retractor in the middle is what we use to do the exposure. And then the cast bar pins are used with the other retractor for the actual disc expansion. And then there's some tamps up there also that we use. Okay, so now, so what we're going to do is we're going to fix the shadow line retractor to the patient using a ray tack. So basically the shadow line retractor system is a good system, but if it's not properly placed, it can move around a little bit. So a lot of times the surgeons will take a ray tack, pull it through, and clamp it down so that it won't move. And then we're going to put some cast bar pins in. So the cast bar pins are in the Asculap cervical distractor system, and they basically go into the anterior body above and below the disc that we're working on. And we put these pins in, and then we distract them so that the disc is open and easier to remove. So males typically use 14 millimeter cast bar pins, and we use 12 millimeters for females. And basically when we're doing this part of the procedure, the surgical assistant will hold retractors, either Clowards or Love retractors, to help with the placement of these distractors. And then during the removal of the disc, the SA will clean the large rungers, the kerricins, the pituitaries. And a lot of times the surgeons will use a drill, so you'll want to irrigate for the drill. You don't want to irrigate constantly, it's more of a intermittent type of thing. And then you'll also want to help suction as well with the Fraser suction. And you definitely want to be aware of the spinal cord exposure. So whenever the surgeon is using the drill, suction, you want to make sure that no one touches the drill, because any energy that's taken can transmit down to where the surgeon's working, and that's not a good thing. Okay, and then so once we get all of the disc out and everything is cleared up, we're going to put in a bone plug or bone graft. And these bone grafts can be an allograft or an autograft. A lot of times we use LifeNet VG2 implants. Some surgeons like to use a hip graft. It just all depends on surgeon preferences. So a lot of times the SA will help to tamp this bone in. We'll use a mallet suction depending on the surgeon's comfort zone. And then we'll also help with the sizing of the plate. We'll figure out what size we need. We'll help with the screws, drilling the holes for the screws. We want to make sure that everything is final tightened, and we do x-rays after that. And then we aid in hemostasis and protection of the esophagus and the carotid artery. So we're always on guard about those things. And then we do a closure of the muscle layer, usually just the platysma is all that's needed. We'll use a 3/0 Vicryl pop-off suture. And then closure of the skin is usually with a 4/0 monocryl or Vicryl. And then dressings per the surgeon, a lot of them use different things. And then usually we'll put a collar on the patient, depending on how many levels we do. So in summary, describing the anatomical and surgical steps. So we talked about the dissection from the skin to the bone. You need to be able to show proficient ability of incision, hemostasis, retraction, and suction. So that's the SA needs to be able to do this effectively. We also complete the skin closure and we put the collar on the patient. And we need to be aware of the drill types, the burrs, the tamps, the plates, and screws. And we need to be able to aid in insertion of the bone plug, helping with tamping, using the mallet, inserting the screws and the plate. And that's all dependent on the surgeon. Some surgeons want to do all of it, some of them let us do a lot of it. It just depends. So next we're going to talk about patient care steps. So this is more stuff for the nurses and the SAs. So we're going to describe the patient care steps before and during surgery. So from start to finish, I kind of wanted to go into detail about this because I've noticed that some new nurses that we have don't understand the proper flow of everything, and they get certain things done instead of others, and it's helpful to know, everything that needs to be done in the right order. So, of course, you have to identify the correct patient in the surgery. They need to know the sterile and non-sterile items to open and to have available. Patient allergies and medicines, that's very important. Documentation, talking to the family, and knowledge of positioning. So, we need to identify the correct patient in sight. So this is very important. You need to properly identify the neurosurgical patient by the wristband and the patient interview. And you need to correctly identify the correct surgery and level and have all available consents. So this is very important to know the level of the surgery, make sure everybody's on the same page, because this could be a very bad thing if you don't have the correct site and level. Okay, so items to open. So depending on the surgeon, there are different surgical trays. The actual instruments used during the procedure and the representative trays. We need to open drapes, different countable items including Raytex and patties, laps. Some surgeons use Kittners and different sutures, so it's all dependent on who you're working with. You need to open the drill. A lot of the surgeons use the Midas Rex. Other ones use the TPS drills. It just depends. And then you'll want to open the hemostatic agents such as Surgiflow, gel foam, and Surgicel. And then the implants, so the bone implants, the plates, and the screws. And usually we'll open up a VG2 bone implant from LifeNet. And then at the end of the case, you want to have the collar available. A lot of times they'll use an Aspen collar because it's versatile for pretty much any patient. It can change size and shape and can adapt to anyone pretty much. There's also Vista collars, which come in different sizes. And then there's also soft collars. So it all depends on what the surgeon likes. So the next thing, patient allergies and medicines. So you need to be aware of latex allergies, of course, when setting up the case. Whatever other allergies need to be known to the entire OR staff. You need to have available thrombin, sometimes antibiotic irrigation, and some surgeons use local anesthetic. So these things here you need to have available. So this is just a picture of some antibiotic that we use in our irrigation, bacitracin. And then here's our thrombin. We use thrombin every case. I've never seen a neck procedure where they didn't use thrombin. Okay, so now documentation. So this is very important, obviously. The in-room time starts the clock. We need to document the line placement, such as arterial lines, Foley's, different IVs, where they're placed. You need to document the timeout, the procedure start and end times. You need to be able to document the implants and verify the procedure was done as planned and nothing was changed. And then with the family, the nurse needs to be able to notify the patient or the family when the procedure has started during the case and upon completion. And be aware of the patient's condition also. So if something's gone wrong during the procedure, you'll want to make sure that the family knows what's going on and they're not out of the blue with that. With positioning, the nurse should be able to properly position the patient with the surgical assistant. So having help with the head, the bumps, the arms, and the foam and pillows and such. So I created this slide to help nurses understand the flow of the procedure and what happens to be effective. So when the patient comes in the room, you want to introduce yourself, give them a warm blanket. The patient will move to the OR table and we will position them. And then anesthesia will put them to sleep, put lines in, we'll make sure that the kennel stockings are on before the patient is intubated. Then we'll do a timeout, and then the patient will be prepped. And then after that happens, the surgery started, so the nurse should be able to open any necessary supplies during the case, count items, do documentation, talk to the family, and at the end of the procedure, they need to help with opening the dressings for the end of the case. So in summary, to describe the patient care steps, you want to properly identify the patient and the correct surgery first and foremost. Open the proper trays and drapes, all the countable items and the drills, the hemostatic agents and implants. The nurse needs to have the correct thrombin available, antibiotic irrigation, and local anesthetic. The nurse should accurately assist with patient positioning and maintain proper documentation. So the next thing we're going to talk about, proper surgical instrumentation setup. So, for surgical instrumentation setup, the surgical technologist should be familiar with these trays. They should know the surgical steps, and they should be aware of the representative trays. So it is very important to have the correct setup. So the tech should know which trays to open based on the surgeon's preferences. They should know each instrument in the tray, how it's used, when it's used. The Mayo stand should be set up properly so that we can effectively use it. And the tech should understand how to set up the drills, which is very important. So this is a picture that I took of a typical Mayo stand. All of these instruments were greatly put out on this Mayo stand, which is nice. So here you have the Clowards, you have your Takahashi, which is a very small pituitary rongeur, and then you have pituitaries and different sized Kerrisons, You'll always want to use the gold tip Kerrisons for any surgical procedure because the foot plate is smaller. Then you'll have your bayonets and your bipolar, your nerve root retractors, and then your curettes, your nerve hooks, and your mets. And then this is another picture. I took pictures of an entire setup here. So this is the left-hand side of the table. So here's your shadow line, which we talked about earlier, which we'll use. And then here's all the other surgical trays that we used alongside it. And this is further on down the table. You have your Kerrisons and curettes, more of them, and rungers, the light handles, and all the other Fraser suckers, and more of the shadow line retractor system there. And then your basic instruments that we use, hemostats, needle drivers, that type of thing. And then here we show all the other things, patties, local anesthetic, different drills, Kittners, the knife blades, and all of our retractors, Wheatlanders and Cerebellars, and there's some flow seal there that hasn't been made, Raytex. So all of those things are very important to have available. So, the proper setup here. So, the tech should be able to anticipate each part of the case. So, during the incision, obviously a knife, Adson forceps, Bovie, we'll use the bipolar. Once we get past the skin, we'll use DeBakey pickups. And then, of course, we talked earlier about Cloward retractors once we get down to the spine. Kittners are helpful with dissection. Bone wax is sometimes used if there's a lot of bleeding in the bone. And then you'll use Surgiflow, suture ties, Penfield 4s, and bayonets. And during the disc removal, some of the main things we use are the Kerrisons 1, 2, and 3, the pituitary rongeurs, the large rongeurs, and then the drill using the Midas or the TPS. A lot of times they'll use a black nerve hook, the knife to remove the disc, curettes, and the Takahashi. And then during the implants, the tech needs to know the bone inserter, which tamp to use, which mallet to use. Different surgeons like a heavier mallet, some of them like a small tamp, it just depends. And then during the closure, you'll want to have Clowards available to check for bleeding, the forceps, suctions, needle drivers, that type of thing. So the representative trays. So the tech should be able to know the geography of these trays and what instruments are in each level of the trays. The tech should know the sizes of the plates and the screws, what type of screws we normally use. They need to know how to load them, how to load the bone into the inserter, specific manual drills. Some of the drills that we use have a variable guide. They should know the difference between locking and variable screws. So some of the screws lock into the plate and it makes a fixed construct. There are also variable screws that can be directed however the surgeon wants. So depending on what's going on, the tech should be able to know whether we're using a locking or a variable screw. We'll also use a plate pin inserter that helps to hold the plate down while we're figuring out if it's in the correct position. They need to know the specific bone tamps, and they also need to have an accurate record of what screws are used and which plate is used. Okay, so in summary, we talked about which trays to open, having the proper Mayo stand set up in the back table. All of this stuff is very important. When we have a knowledgeable tech, a neurotech, it really makes everything much easier. The tech should anticipate the instruments needed for each part of the case during the incision, the removal of the disc, the implants, and the closure. The tech should know the geography of the rep trays, the types of plates and screws, how to load each item, and have an accurate recording of the plate and the screws used. So next we're going to talk about proper handling of the instruments. So this is knowing the accurate technique of handing off an instrument. This is more for techs that are new and are trying to be familiar with the type of instruments, and sometimes the tech will not know how to hand something. So I figured I would talk about this a little bit just because I have encountered this type of problem before. So the tech should know the working end of the instrument. So, technique. So you should hand each instrument carefully and without hesitation to the surgeon or surgical assistant without their need to look up. So basically here, the tech should know how to hand it so that the doctor does not need to look in order to hold it or use it. The same thing goes for the SA. They should give the doctor the handle of the instrument so he can use it without rearranging it. The screws should be loaded securely. They shouldn't ever fall off. A lot of times techs will use bone wax to hold the screws on. And the bone plug needs to be obviously secured. I've seen a few instances where the VG2 implant was not placed correctly on the inserter and it moved around. So it's very important to understand how to load. And then also, you should not touch the drill or suction while it's being used, as I mentioned before, because whatever movement is put on these things can transfer down to where the working end is. And then maintain safety of the drill when assembled, so you should test the drill when changing bits. So this is very important for the tech to understand how the drills work and the correct usage of the bits. And of course, maintain safety of the knife when passed. That's, but that's important. So, know the working end of the instrument. So the tech needs to be familiar with the use of the instruments. Another tidbit I wanted to add with this case in particular is the tech should always offer patties after using SurgiFlow. It's kind of a step-by-step sort of thing. It always helps to anticipate the procedure, and if the surgeon asks for SurgiFlow, always hand a patty. That always helps. And then there should always be attention to detail when the patient may have a transmittable disease. So in summary, the tech should hand each instrument carefully to the surgeon and the assistant. They should load the screws and the bone plug securely and maintain the safety of the drill when assembled and test the drill when the drill bits are changed. So the next thing I'm going to talk about is knowing your role. So, knowing your role. So understanding of surgical dynamics and teamwork and scope of practice. So here I wanted to talk about this because I think there are a lot of things that go on during the case where certain people want to do certain things and they need to understand everyone has a place, everyone does an important job, and there usually isn't a transferable with work. Everyone has a job for a reason. And the scope of practice is basically what you are allowed to do in the surgery based on your job description. And the surgical assistants have a larger scope of practice than the techs. The nurses can do different things that the SAs can't do. So it all depends, and everybody works together, and that's what teamwork is all about. So talking about teamwork, everyone needs to comprehend your job's role in the case. Like I was saying earlier, everybody has an important role. We should understand the importance of each team player. Let each role complete their specific tasks. So basically, I'm saying here, let everyone do their job and try not to step on other people's toes. Let people, do what they need to do. And don't assume another role will pick up if you didn't finish something. And know what is expected of your role for effective communication. And then ask for help if you need it. Especially with new people, there tends to be a lot more of that. And just helping each other out, because if you have an experienced person in the room, that helps a lot when you have a new person. They can let them know what's going on. So, scope of practice. So, know your scope of practice. Being disrespectful creates a hostile work environment, and pay attention to your job description. So, this seems to be more of an issue with the SAs versus the techs. It's kind of an interesting thing. Depending on the tech and well, it's really the dynamic that can happen during the case. It's just important to know what you are able to do and what you're comfortable doing, and then basically just go from there. And whatever the surgeon says is okay as well. So in summary, you should know your job's role in the case. You should understand the importance of each team player. Know what is expected of your role, and know your scope of practice. And pay attention to your job description. And finally, I'm going to talk about alternatives in surgical methods. So here I listed a bunch of things that can vary based on the surgeon. So different surgeons can use different implants. A lot of them use the VG2 LifeNet bones, but some surgeons use cages. They'll use hip grafts. With positioning, pretty much everyone does the same thing. They will tape or use wrist restraints. But everyone pretty much papooses the arms, and that's pretty standard. The drills can change. A lot of the doctors use the Midas Rex. They can also use a TPS drill. As far as dressings go, a lot of them use steri strips and opsites. The newer thing now is to use the surgical glue. But that's not as common, but they sometimes use that. And then hemostatic agents, pretty much all of them use Surgiflow, but some use Surgicel instead. And then with the x-rays, most surgeons use a C-arm, but some surgeons use a flat plate, but that's kind of rare. And then with the collars, you have the hard and the soft collars, the Vista, so different things, and antibiotic irrigation. So, in conclusion, so these are the things that we've talked about during my presentation. So we've talked about the positioning items and what's needed. We've talked about anatomy. We've talked about the steps during the case. We've described the patient care steps before and during surgery. We've discussed the correct surgical instrumentation setup, what a Mayo stand should look like, what sorts of things need to be available, and the correct setup of everything. We've talked about the proper handling of instruments. We've talked about knowing your role and how important that is. And then we've also mentioned alternatives and methods based on doctors' preferences. So thank you very much for watching and listening. I hope you all enjoyed this. These were my references. These were two of the books that I used for the different pictures during the procedure, and then also some of the more specific stuff on my anatomy. And then to end, I have a quiz. So good luck with the quiz, and thank you very much.